Hi all, it's Nathan, trans midwife here. This video is targeted at you awesome birth workers such as midwives, midwifery support workers, student midwives, doulas and doctors, and is designed to specifically give you clear answers about caring for trans people in maternity. The title is Trans-masculine and non-binary folk who are able to carry, birth and feed little humans. Something very poorly understood is childbearing after medical transition has already commenced. Disclaimer: someone identifying as male or non-binary and using he, him or they, them pronouns is common before or without any medical intervention, and their identity is valid and should be respected regardless of their outer appearance. You do not need to ever have or want any medical transition to be trans. So, about testosterone. Medical transition for people with reproductive organs capable of childbearing, usually with the goal to masculinize or appear more androgynous, can include the following: taking testosterone, having top surgery or a mastectomy to remove breast tissue and make the chest appear more masculine, and bottom surgery or lower surgery, which is complex and can take several years to complete. Trans people who have been on testosterone for years and have grown full facial hair and appear outwardly male are able to come off testosterone, allow their menstrual cycles to return, and conceive, carry and birth a healthy baby. And they have many times. It is very important that they are no longer taking testosterone while pregnant if they want to continue with the pregnancy, of course. Accidental conception can happen, and testosterone is teratogenic or harmful to the fetus. The healthcare professional should give this advice without hesitation. Immediately discontinue testosterone and see their gender specialist doctor urgently. Infant feeding. Trans people may be pre or post-top surgery when they decide to carry a child. If they're pre-top surgery, they may or may not plan to feed their baby their own milk like any other new parent. However, extra sensitivity is required here for trans people. Some trans people prefer to refer to their breasts or chest as any number of nicknames. If in doubt, ask. Example: how would you like me to refer to your chest when discussing infant feeding? Testosterone as a medication has a short half-life in the body of less than 2 weeks, so there is no concern about their human milk for their baby if they've taken testosterone in the past. There is currently no evidence that allows us to properly assess the risks and benefits of continuing to feed their baby while recommencing testosterone after birth, unfortunately. But it is likely that there would only be traces in the milk. We currently do not know. A common question that's come up is, if they have had top surgery, will the breasts grow back or change during pregnancy? During top surgery, unless they have had a reduction, all or most of the breast tissue is removed, so the breasts will not grow back, although anecdotal evidence tells us that some of the remaining tissue can swell and lactate in small amounts. Also, natural pregnancy weight gain and the lack of testosterone might make their chests appear puffy or larger, which might feel upsetting. This experience varies greatly from no change at all to quite a significant change. Cesarean birth considerations. Being trans-masculine or non-binary and the potential dysphoria and or complex feelings about the body and childbirth is reason enough to offer informed choice about elective cesarean birth. Testosterone usually, but not always, has several effects on the genitals of an AFAB, assigned female at birth person. It can cause the clitoris to grow, appear and act more like a small penis. It also can cause atrophy of the vaginal soft tissues, which means that they can be thinner, more sore and sensitive, and tear and bleed easily. Lower surgery. It is rarer, but still possible that a trans person may have had gender confirmation surgery on their genitalia before choosing to carry a child. In these circumstances, a referral to a consultant is necessary to discuss the options, but it is likely that an elective caesarean birth will need to be seriously considered. They may still be able to birth through their genitals, but there might be a risk that surgery results will be permanently altered. It is important to note that not all trans people will want a caesarean birth. Many prefer to birth through their genitals and will vary in feelings about hospital, birth centre and home birth like all parents. Home birth may feel far safer to a trans person than a hospital birth of any kind. More points to consider. If trans people opt for a birth centre or hospital birth, it would be ideal to offer a private room and bathroom wherever possible. However, always make this an offer, not an assumption, as we do not want them to feel segregated for being different either. Trans people may not want their gender identity clinic to know that they are pregnant if they're waiting for referrals for surgery to go through. You must discuss with the person whether they want to inform their gender identity clinic themselves or if you want to contact them. Being trans or having been on testosterone and or having had top surgery in the past are not reasons to refer for consultant-led care. The only reasons to refer to a consultant are having been on testosterone during the start or some of the pregnancy, or where caesarean birth is being considered for any of the above reasons. Trans assigned at female birth people who have not had a hysterectomy need to be offered smear tests as well, as just an afterthought. Thank you for taking the time to expand your knowledge by listening to me. This video is all written by me and is intended to inform on something. However, there is very little academic research out there at the moment, so it is mostly anecdotal evidence-based. Please carry it forwards and continue to serve. Sending love and gratitude from me. Thank you.